Thank you very much. I appreciated your very elegant introduction, and I'm very glad to be here with you in this session. My case today is a very simple case, but I want to give some facts in our nuclear medicine or our lab. This case is a 54 years old woman presented with typical exertional chest pain, Canadian class 3. Risk factors of this patient is known to be hypertensive and dyslipidemic, no prior coronary artery disease. So its pre-test probability is intermediate. And this is a main issue of today, that we will focus on the patient with intermediate risk probability of ischemic heart disease, how to intervene with them. So initial investigation, ECG was normal, high sensitivity troponin was negative, a transthoracic echo is normal LV size and function, ejection fraction in 60%, and no segmental wall motion abnormality. So there is no structural explanation of the symptoms yet, but the clinical clue is the typical of chest pain, typicality of chest pain. So we go to the third step, which is coronary angio. We do coronary angio for here. Left main artery was normal. LAD and LCX RCA was no obstructive lesions. With STEMI floor 3, there is a normal coronaries, but still the symptoms is the clue of us. It's a typical chest pain with a typical risk factors. So our first fact I wanted to give it to you today is that a normal ECG, normal echo, and normal angiography still didn't mean that the patient has absence of myocardial ischemia. Why we do expect for here? Why is physiology is important? Because the angiogram just only assess the lumen, but not the flow. The microcirculation is invisible to the angiogram, and ischemia is a physiological phenomenon. And this is our second fact, that is the physiology is important still than the anatomy. So angiogram by the coronary angio showing stenosis or severity of stenosis, show epicardial vessels, shows the lumens, but the physiology showing the ischemia burden, showing the micro and the macro circulation, and also the flow and function. So our next fact today in our presentation is modern cardiology is more physiological driven than the anatomy with the classical teaching. So the guidelines in the ACC 2024 and the BCI in UNOCA consensus showing that is a functional assessment is considering as a class 1 for this patient with low and intermediate risk probability to assess either they have a microvascular or microcirculation abnormality or microvascular dysfunction or not. And this is the guidelines showing the most important category, the patient with moderate and high risk category of developing coronary artery disease. First priority is functional imaging, not just anatomical imaging as we learned by SPECT or PET scan or CMR, and stress echo is still tools to assess patient with high and intermediate risk probability, which are considering most probability of the patient with acute coronary syndromes. So functional imaging we used was SPECT. This is a SPECT perfusion finding of this patient. As we see, there is no focal reversible perfusion defect, just mild diffuse reduction in stress tracer uptake, and no territorial ischemic pattern. So perfusion alone is not insufficient or not just dependable. Perfusion imaging is good to diagnose ischemia, to diagnose the microvascular circulation, but it's not insufficient. So the fact number 3 is perfusion alone is insufficient. So we should do gated SPECT, which showing more data on the physiological pattern of the microcirculation, which shows that some sort of red flags of SPECT gated scan, that stress LV ejection fraction dropped by around 16% from 62 in the baseline to 46 in the stress ECG, LV ejection fraction, by 16% dropout, transient global hypokinesia, and normal wall motion at rest. So stress-induced myocardial dysfunction was driven in this patient, and this patient diagnosed as having microvascular circulation or some sort of new terms, Minoka or Inoka, as we will tell you later. So the physiological interpretation for this patient, he have a diffuse ischemia, impaired chronic flow reserve, and the coronary microvascular dysfunction. So is this consistent with microvascular angina or Inoka, which a new term from 2024. Why was SPECT is helpful? Because the initial tools, ECG, the echo, and angiogram was normal, but the only who detect the microvascular circulation abnormality was SPECT. So this is factor number 4. Physiology explained these symptoms, not the anatomy. And I want to tell you about the SPECT red flags, which if we see in the examination of a patient, we should raise the red flags and diagnose this patient with a microvascular circulation in form of transient ischemic dilatation, stress-induced LV ejection drop more than 10 to 15%, which happened to our patient, small LV or global low counts, transient wall motion abnormality, clinical imaging mismatch, some sort of patient having the typical chest pain during the stress, but the SPECT still go normal, and increased lung uptake, which is one of major markers of ischemia. So this marker clinically signified a patient have ischemia or not. A role of SPECT in microvascular circulation or microvascular angina, it's confirmed ischemia by in the absence of true stenosis in the coronary angio, provide a prognostic stratification, guides medical therapy, which is very important after even the diagnosis, and prevent mislabeling the patient that he is not having any anatomical chest stenosis or chest pain, so a patient is not ischemic, but the physiology diagnoses the patient is having ischemic heart disease. So if anatomy is normal, but physiology is abnormal, the patient still have ischemic heart disease, and SPECT is a good for diagnosis, risk stratification, and treatment appropriately. So my take-home message, normal angiogram doesn't exclude ischemia. Inoka and Minoka are common and prognostically relevant, especially in this era of after COVID. Functional assessment is guideline recommended. SPECT remain a cornerstone physiological tool, which is very important in our era. Physiology should guide management. And to my conclusion, in the era of Inoka and Minoka, cardiac SPECT has an emerging and upgraded role. Physiology is still a truth. Thank you.